Okay. So today I am going to be talking about the new ACR-VF guideline in Takayasu's arteritis. I'm Anisha Dua. I'm an associate professor and the director of the Vasculitis Center and the Rheumatology Fellowship Program Director at Northwestern University Feinberg School of Medicine. So Takayasu's arteritis is characterized by granulomatous inflammation of the large blood vessels. We know that this is a rare vasculitis, usually affecting patients in their young ages between 15 to 30, and it has a female predominance. Some of the clinical presenting manifestations are constitutional symptoms, including fevers, malaise, fatigue, weight loss. Patients can present with limb claudication, which is soreness in the arms and legs with activity, hypertension, symptoms such as dizziness and vertigo, and also tenderness over some of their blood vessels, like over the carotid in the neck. If we get pathology on these patients, what we expect to see is aortic wall thickness and some scarring in the adventitial layer of the artery, although it's very difficult to get pathology from these large blood vessels. So the arteries that are most commonly affected in Takayasu's include the bilateral carotid arteries, the left subclavian, the abdominal vasculature, including the celiac and mesenteric arteries, the renal artery, which can lead to the hypertension, and involvement of the infrarenal aorta. And depending on the blood vessels that are inflamed and involved, downstream from those blood vessels is where you end up getting the clinical manifestations that the patients are presenting with. When we think about the ACR classification criteria for Takayasu's, again, we know that this usually starts at a young age, so less than 40 years. Claudication in the extremities is one of the criteria. We are always checking pulses and measuring blood pressures in all 4 extremities at our clinic visits to look for any of those changes, and listening over all of the blood vessels for bruits or turbulent flow in that blood vessel. Again, because we usually can't get pathology, we tend to rely pretty heavily on some sort of arteriogram or radiology abnormality to help us get a better idea of what's going on inside the blood vessels. So what makes Takayasu's difficult? Again, the clinical presentation is not very specific. So patients can have these symptoms and it's kind of hard to pinpoint it down before there's been a lot of inflammation and sometimes after damage has already occurred. We also don't have reliable biomarkers to diagnose the disease or monitor the disease. The ones that we do use are not completely specific for Takayasu's and not always completely reliable. And then, of course, as I mentioned, the pathology, because it's these larger blood vessels that are involved, is rarely obtained. So this results in a delay in the diagnosis and a lot more damage before we can identify these patients. And it also leads us to rely quite heavily on imaging modalities to try to give us information about what's going on. So we're going to talk about this through a case. And this is a 20-year-old female who comes in with fatigue, malaise, fevers, dizziness, and tenderness over the left side of her neck. Her labs show elevated inflammatory markers, and that is your SED rate and your C-reactive protein. And blood pressure in her left arm is higher than her right arm. Imaging studies confirm that she has active vasculitis in the left common carotid artery and the left subclavian artery. So here you can see a PET scan showing increased uptake in the carotid, which is that bright yellow spot, and also in the subclavian, which is that other bright yellow spot marked by the yellow arrow. So this active inflammation eventually can lead to damage, which manifests as stenosis or narrowing of the artery, or it can eventually sometimes lead to aneurysms where the artery becomes more floppy. So in patients with Takayasu's, we recommend non-invasive imaging over catheter-based dye angiography as a disease activity assessment tool. Now, what that means is, we occasionally will use catheter dye-based angiography, and that's really to help pre-surgical interventions when we're trying to get accurate blood pressures and get a very clear picture of what's going on for a surgical intervention. Generally speaking, though, we tend to use other types of non-invasive imaging modalities, especially in Takayasu's. We rely heavily on MRA. And that's because these patients, again, are being diagnosed at a young age, and MRA avoids the repeat radiation that's associated with CT angiography. It can tell us about what's going on in the blood vessel wall without exposing that patient to repeated courses of radiation. So our patient has new active severe Takayasu's, and we define severe disease as organ or life-threatening disease. Now the question becomes, what should we start next? And in severe active Takayasus, we recommend starting high dose oral glucocorticoids. And that's over pulse, which is IV glucocorticoids, or low dose glucocorticoids. In some cases, when there's life or organ threatening disease, some practitioners will use pulse steroids, but the general recommendation is to use high dose oral steroids. And at the same time, we want to use another non-glucocorticoid immunosuppressive agent added when we start those steroids. And when we think about what those other agents are, we have a list. And so non-glucocorticoid immunosuppressive agents, the goal is to try to use these to help control the inflammation, and then eventually allow for us to use less steroids, which can lead, we know, to a lot of different side effects. The options include methotrexate, azathioprine, mycophenolate, and leflunomide. Now, methotrexate is preferred in the pediatric population, but you do have to think about patient factors such as childbearing plans, alcohol use, comorbid disease. For example, methotrexate is not an ideal choice in somebody who is having either kidney issues and kidney issues, or having any sort of plans for having a child soon, because methotrexate can be toxic to the fetus. Other options include azathioprine, leflunomide, and mycophenolate, like I mentioned, and there are no major head-to-head trials saying that one is necessarily better than the other. So a lot of times this comes down to a conversation between the provider and the patient and deciding what would work best for that patient. The use of glucocorticoid monotherapy should be rare, but we do use this sometimes if the disease is very mild or if there's some diagnostic uncertainty. So we're going to start looking on the red box and just talking about how to treat active Takayasus. So again, if they are not on immunosuppressive therapy, the first step is adding high dose daily oral glucocorticoids and a non-glucocorticoid immunosuppressive agent. The goal here is to try to get them into clinical remission. And what we think of as clinical remission is no clinical symptoms on or off immunosuppression. Beyond that, we have to talk about what to do with their steroids and then what else we can use if we can't get them into clinical remission. And I'll talk a little bit about that in the next few slides. So our patient is started on methotrexate, and we titrate the dose to 20 milligrams a week along with the glucocorticoids. Her carotidinea, or neck tenderness, initially improved, but now it's worsening as we're tapering down those steroids to doses below 20 milligrams a day. So what can we add for disease control? In patients with refractory Takayasus on glucocorticoid therapy, we recommend adding a TNF inhibitor over adding tocilizumab. So again, this patient has already been started on the glucocorticoids, tapered down, and they've also been started on the methotrexate, but we're unable to get the steroids low enough without relapsing of her disease. So in this case, we want to add a TNF inhibitor. This is the first line biologic in Takayasus, and this includes adalimumab, infliximab, and some others. There are some other options that have been tried in Takayasus, and that includes tocilizumab, abatacept. Both of these drugs failed the randomized control trial, but we do use them occasionally in refractory disease after trying a TNF inhibitor. Other options that have less experience, but we also have used in cases, include rituximab, ustekinumab, and tofacitinib. So in refractory disease, these are all options, but the first line option in our recommendations would be to use a TNF inhibitor. So we decide to add adalimumab, a TNF inhibitor, every other week to her methotrexate and the prednisone, and her neck tenderness and lightheadedness improves, as does her imaging. So again, this highlights the importance of checking imaging regularly. And you can see here in the one image, you have that increased yellow uptake showing inflammation of the blood vessels. And with this medication regimen, her enhancement, or that bright yellow spot, has resolved. So she no longer has inflammation in those blood vessels. So now what do we do? How can we monitor her disease activity? In patients with Takayasus who are in apparent remission, we strongly recommend long-term clinical monitoring every 3 to 12 months over no clinical monitoring. This basically means that we are going to see you in clinic regularly and examine you and ask you about your symptoms. Some of the things we consider in terms of how often to see patients and monitor them include how long they've been in remission, the sites of the blood vessels involved. There are some types of blood vessels which might be more risky, and we might want to monitor those patients a little bit more closely. Their risks for disease progression, what immunosuppressive therapy they are on, And also, how reliable are the patients in recognizing or noticing some of the symptoms of their disease? Because like I mentioned, they can be difficult to identify. And this will help us determine how often to do our regular clinical visits. In terms of laboratory monitoring, I mentioned there's no ideal biomarker for Takayasu's, but in patients with Takayasu's, we do recommend adding inflammatory markers to monitoring as a disease activity assessment tool. Now, we know that this is not a perfect indicator of disease activity. The sedimentation rate and the C-reactive protein can both go up for many other reasons, including infections or other autoimmune diseases. There's a lot of different things that can drive these markers to be abnormal, but we still tend to check them regularly in our patients to see if they can help guide us in terms of our thought process and our treatment. The other thing that we use, as I mentioned, is radiography. So in patients with known Takayasu's, we recommend regularly scheduled non-invasive imaging. Now, this can be done every 6 to 12 months, but we do this along with our routine clinical assessment and our checking of our inflammatory markers. How often we want to do these imaging studies may be shorter earlier in the disease course. So soon after diagnosis, we might check it again in 6 months. And if the patient's been in remission for a while and been doing well, then we might start spacing out that regimen of how often we're checking this MRA. So let's go back to our case. She clinically improves. Her inflammatory markers remain normal on repeat testing, and her imaging studies do not show any progressive or new lesions the following year. So now that she's achieved remission, do we continue the prednisone 5 milligrams daily, or do we try to wean off the steroids completely? We all know that prednisone has significant side effects, including weight gain, cataracts, osteoporosis, hypertension, diabetes. And we all know that it's sort of double-edged. We need to use it to try to gain control of the disease, but we want to minimize it as much as possible, right? Because of all these side effects. So in patients with Takayasu's who achieved remission on glucocorticoids for at least 6 to 12 months, we recommend actually tapering off the glucocorticoids over maintaining them on a long-term low-dose course. So if possible, our goal for steroids is 0. And now the optimal duration of steroids in Takayasu's is unknown, but we recommend limiting the exposure if possible, again, given the toxicities of glucocorticoid use. Glucocorticoids may be continued for a longer duration if the disease is not adequately controlled. So if the patient is experiencing multiple relapses, and we're just unable to get it under completely tight control, we may use low-dose steroids for a longer period of time in our patients. So what if we start weaning down the prednisone and she remains clinically stable? So we're taking her off the steroids and she's doing well, but we're checking that lab test. And we know that on routine screening, her sedimentation rate starts to rise on her repeat studies. So in patients with Takayasu's in apparent clinical remission, but with rising inflammatory markers, we recommend clinical observation without escalation of immunosuppression. Now, this might make us think, okay, there might be something early going on, or we want to watch them more closely. So we may check their lab values more often or bring them in for more clinic visits to make sure that nothing is evolving. But we do not escalate treatment based on the number solely alone from that lab test. So a year and a half later, she comes in for follow-up and she tells you that she has now some new symptoms. She has intermittent symptoms of left arm pain when she's doing activities, and we call this claudication. These symptoms occurred with variable degrees of activity. So when she's carrying her groceries, putting away dishes, drying her hair, she notices that her left arm really starts to become sore. We decide to get some repeat imaging at that point, and we get an MR angiography, which reveals a new high-grade stenosis in the proximal left subclavian artery at that site of initial PET activity. So remember, I showed you that imaging that showed that increased uptake, and we now are seeing an area of stenosis where that inflammation originally was. You can see here in the 2017 image that there is clear blood flow going through that subclavian artery, even though there was inflammation on that PET scan. But over time, that inflammation has resulted in some damage to the artery. And in 2019, you can see that there's stenosis, meaning that artery has been blocked off and you can no longer see that nice white blood flow going through the subclavian. So now we're going to move on to the other side of this figure and talk about what to do when we start seeing some of these abnormalities or changes on our MRA or imaging studies that we're doing in our patients. So when we have vascular changes and we see a progression of an existing vascular lesion, but the patient has no symptoms, and they're asymptomatic, so they don't have any findings of active disease on imaging, then we want to continue treatment and monitor them. Now, if they start having symptoms or they have active disease on imaging, then we're going to escalate immunosuppression. And lastly, we're checking the MRA regularly to look for inflammation. So what we're looking for is stenosis or vessel wall thickening in a new vascular territory. This means that there's new areas of active disease. And in that case, of course, we would escalate immunosuppression. And then we go on to talk a little bit about surgical intervention. So in patients with known Takayasus and persistent limb claudication without evidence of ongoing active disease, we recommend actually against surgical intervention. Now, this is because a lot of the times this process is relatively slow and collateral circulation can develop. And so basically the area that's become damaged and blocked off, new blood vessels can form around that area and basically connect and supply blood past that area of stenosis and still allow for blood flow to the critical organs. So if possible, and there's, there's limb claudication, but you still don't have evidence of ongoing new lesions or active disease, we basically would recommend trying to treat medically and not use surgical interventions. If possible, we delay surgical interventions until the disease's activity is controlled. So basically, we would ideally not go in and perform a surgical intervention or put in a graft or mess with the blood vessel when it's actively inflamed. So ideally, when somebody is having new inflammation, we try to get it under control first and then talk with the vascular surgeons. Some situations, this isn't possible. And some of the situations that would warrant immediate consideration of a surgical intervention include life or organ threatening manifestations, such as a stroke, loss of viability of a limb, or a heart attack. Now, these are cases where you have to go in and intervene and you can't wait for the disease activity to become under control. But for those patients who do require this type of urgent surgical vascular intervention, the type and the timing of the intervention should definitely require a collaboration between the rheumatologist and the vascular surgeon. So we need to discuss with them how to best manage our patients. So our patient, she decides that she actually wants to undergo a surgical intervention. She plays the guitar in a band and the claudication symptoms are significantly affecting her ability to play. So even though there's a possibility of collateral circulation developing, she really would like to open up that blood vessel or bypass that blood vessel so that way she can perform. So in her case, she wants to undergo a surgical intervention. And in those patients, we recommend using high dose glucocorticoids peri-procedurally, so around the time of the procedure if they have active disease. Now, if the patient doesn't have active disease, then you might not need high dose steroids. But again, as I mentioned, disease activity can be difficult to assess. So a lot of the times we will preemptively use some glucocorticoids around the time of surgical intervention. So our patient has a stent placed in the left subclavian with resolution of her arm pain symptoms. She continues on adalimumab and methotrexate and is successfully weaned off of prednisone with no recurrence of her clinical symptoms or evidence of radiographic progression on subsequent imaging. So I just want to highlight a couple of special considerations that we need to keep in mind. In Takayasu's patients with stenosis of a cranial or cervical vessel without clinical symptoms, we recommend medical management over surgical intervention. Medical therapy is recommended only if a single vessel is involved due to the substantial risks that are associated with a surgery. Now, sometimes when more than one blood vessel is involved, then surgical interventions can be considered. Another thing to think about is the renal artery. So in Takayasu's patients with renovascular hypertension and renal artery stenosis, we recommend medical management over surgical intervention. Now, what's happening here is that the renal blood vessel is becoming closed off or stenotic, and this can lead to high blood pressure. And what we want to do with medical management is control that blood pressure with antihypertensive medications and use immunosuppression for active inflammation for the Takayasus. In some cases, surgical intervention, including catheter-based, is considered. And that's really done if the hypertension is really refractory to treatment or if we see signs of some worsening renal function. And the last special consideration I want to talk about is pregnancy. Now, as I mentioned, Takayasu's often affects a younger and predominantly female population. So this is something that we need to discuss with our patients. We know that poor pregnancy outcomes in Takayasu's are associated with smoking, abdominal aorta or renal involvement, and with active disease. So we want to do our best to control the disease activity and get patients into remission before they try to conceive. If you compare Takayasu's patients with the healthy population, you can see here that a lot of these complications are more common in our Takayasu's patients, including hypertensive disorders, the need for getting cesarean sections, prematurity, and intrauterine growth retardation. So these are all things that are seen more in Takayasu's than the healthy population. But when we look at active versus inactive Takayasu's, you can clearly see that patients with active disease are at much higher risk of these obstetric complications and preeclampsia than those with inactive disease. So again, what we're trying to do really is control the disease, get patients into remission before becoming pregnant if possible. More than 5% of pregnant women with Takayasu's can develop a life-threatening maternal cardiovascular complication. So we are watching these patients very closely throughout their pregnancy. And these pregnancies should be considered high risk. So we need to make sure that we're having good, clear communication between the rheumatologist, cardiologist if they're involved, and of course the maternal fetal high-risk OB doctor. So the take-home points here are that in patients with active Takayasu's, high-dose oral glucocorticoids should be initiated along with a non-glucocorticoid immunosuppressive agent. As I said, these include methotrexate, azathioprine, mycophenolate, and leflunomide, and the choice of which one to use would become a decision based on patient preferences, comorbidities, and talking with the physician. Now, if you're not able to get the disease into control, so you have refractory disease, then TNF inhibitors should be considered before tocilizumab, abatacept, rituximab, or ustekinumab. All these other agents can be used, but the first line treatment would be a TNF inhibitor. Takayasu's patients should be monitored at regular intervals with a clinical exam where we're listening to your blood vessels, listening for bruits, checking your pulses, getting blood pressure measurements in your extremities. We should also be checking your SED rate and C-reactive protein, as well as non-invasive imaging studies. So we use all of these different tools to try to figure out what's going on and is the disease active, and do we need to change our therapies. In Takayasu's patients who are in clinical remission, our goal is to wean completely off of steroids. Now we are going to be checking the SED rate and CRP, and if we see a rise in the SED rate and CRP, we will continue to monitor without changing the immunosuppressive therapy, but we might just be checking things a little bit more often and having clinical visits more often. If we see progression of a previously identified radiographic lesion, we would monitor it. We don't necessarily intervene if there's slight progression from a previously identified lesion. However, if we notice a new vascular lesion or rapid progression of a previously identified lesion, that would prompt escalation in immunosuppression therapy. So we're looking for new changes or very rapid progression in the areas that have already been affected to decide whether or not we want to use more immunosuppression. And in Takayasu's patients who are clinically worsening with signs of limb or organ ischemia, immunosuppression should be escalated, and this is even in single vessel cerebral or renal disease, and surgical intervention should be delayed if possible until the disease is quiescent. High-dose steroids should be used peri-procedurally to try to decrease the complications from surgery. And again, this treatment of Takayasu's is really a collaborative process. We need to involve the patient, the vascular surgeon, pathologist, radiologist, rheumatologist. We all need to be discussing our vision and our idea of what's going on to get a better sense of the entire situation so we can make sure that we get the disease under control, minimize complications and side effects, and really improve the quality of life of our patients. Thank you so much for listening.